start with welcoming Dr. STANZIN.
Sir, we are live now.
Maybe I'll just start and ask our president sir to kind of welcome the speaker. So good evening, viewers. This is Dr. Nirmal Kumar, Secretary JHARKHAND Orthopaedic Association, and it's our privilege to have you on this webinar. This is going to be a musculoskeletal radiology series, and in the first part of the series, we have with us today's speaker, Dr. STANZIN, and she is assistant professor from a very reputed institution, that's All India Institute of Medical Sciences, New Delhi, and she specializes in musculoskeletal radiology. So to start with, I would request Dr. Manjeet Singh Sandhu sir, President JHARKHAND Orthopaedic Association, to address and welcome Dr. STANZIN.
Good evening, everybody. So this is the first webinar of this series. I thank Dr. Nirmal for initiating the process. We have seen Dr. Nirmal has done many webinars pre-COVID and COVID times, and we learned a lot during sitting in the home. And the topic is very good and interesting because most of you doesn't know an MRI reading, at least finer points. And MRI is now day-to-day practice, and every patient even knows that they ask for MRI also. So welcome, Dr. STANZIN. We'll hear from you.
Thank you, sir.
Thank you.
Sir, shall I share my screen?
Yeah, sure.
So can I start? Shall I start, sir?
Yes, madam.
Okay. Very good evening, everyone. At the outset, I would like to thank Dr. Nirmal and his team and all the organizers of JHARKHAND Orthopaedic Association for inviting me in the first place. And secondly, of course, organizing this series of webinar. It will be helpful not only for the orthopedic, but also for me and my fellow residents. So yeah, we'll start we have planned it in such a way that initially we'll do only the normal anatomy, because it's so crucial, especially when it comes to musculoskeletal radiology, that we are able to identify the structures. Only then we'll be able to tell if there is any pathology. So first, some normal anatomy of various joints, followed by pathology lectures. So today we'll focus only on the normal anatomy. So having said that, it's also crucial, like, I mean, of course, you all, most of you are orthopedic surgeons, so you would know better that clinical finding is so much more important than what we just see on imaging, because there may be so many findings that we see on MRI with some signal alteration or some variable appearance here and there, but that may not have any significance if it is not replicated clinically. So it's of course important to correlate the two. And most of the time in our routine practice, when we see the images, definitely we keep into consideration the clinical picture that has been provided to us. And also secondly, we also, as radiologists, we prefer to see the patient and ask them for symptoms all over again, just to know the exact site or the site of maximum site of tenderness or the swelling, so that we are mostly doing a point of care type of imaging. But again, not, not forgetting to see the other parts, because there may be some areas which may be responsible for the pain or the symptom, which we may miss out if we focus only on one side. So okay, so we'll start off. So before that, as far as I know, most of the clinicians have difficulty in identifying the MRI sequences, or when they're provided with the films, they're not able to tell which is the T1 or the T2 or the PD weighted sequence. So I'll briefly touch upon that. Then I'll show all the structures On the MRI, one of the normal patient MRI that I have, I'll just show it on the case itself. So I think that will be better for you to get a practical review of the same. Okay. So as far as the sequences are concerned, the most common indication for which we need to get an MRI done, MRI of the knee that we get a requisition for, are mostly because of internal derangements and to look for some pathology in the ligaments or the meniscal structures. So when we want to visualize those things, we mostly rely upon the proton density images, that is PD weighted images, the T1 or the T2 weighted images. So we use either the PD or T2, but mostly it's the PD weighted images. So they look very similar, especially if you see in an extremity, PD has a very important role. While the T1, the usual T1 weighted sequences that we see in which are extensively utilized in other parts of the body, is not all that important when it comes to just looking at the ligaments. So I'll just show two images here. Okay, so this is again MRI coronal image of a patient. So this is the T1 weighted images and this is PD weighted images. So and one thing that you need to see is that whether it is fat suppressed or not. So how you can identify is the look for the subcutaneous fat. If it appears bright, then of course you're seeing the fat signal. So on the other side, are you able to see my cursor?
Yeah.
Okay.
We
So
are able to see, but sorry to interrupt, Dr. Standing. If you could just make it full screen, because we are able to see the rest of the things also.
oh, okay.
So,
So this
मैं ही
is
बोला साथ हो जाने को तुम लगा ले इसको
like the way we go for a PPT. So
actually this is not a PPT, sir.
let's keep.
This is actually the viewer. This is how we see the MRI. So is this
Right.
better?
This is better. This is what I was asking. Yeah.
Okay.
Please
Okay.
go ahead.
Okay, sir. So, okay. So this is a fat suppressed image. You can just simply look at the subcutaneous fat. And if you see that this is dark, that means it is fat suppressed image. So why do we need a fat suppression when we image these peripheral structures? Is because the bony marrow. So this whole area is majorly the marrow. So marrow has a lot of fat, and especially in the long bones, most of the marrow is fatty marrow. So they all appear completely bright. But we want to see some edema or if there is some contusion, which will also appear bright. So if unless we suppress this bright signal, which is coming from a normal marrow, we won't be able to see the edema or the contusion standing out. That's why we always want to suppress the fat. That's why you can see that this is a PD weighted image and it is a fat suppressed image, so that we are able to see the edema or contusion better. On the other hand, this is a non-fat suppressed image where we can see that the whole bone marrow is appearing very bright. That is because of the fatty marrow. And so even if there was some edema around somewhere here in the tibial plateau, we will not be able to appreciate it better. But what is a non-fat suppressed T1 weighted image good for is to look for like thin hypointense fracture lines. So if because the fracture lines will appear hypointense on all sequence. So if there is a hypointense line, of course, it will be better seen when the rest of the bone is bright. So we'll be able to see the line separately. While on a fat suppressed, that may be difficult to see, but we will be able to see the contusion better. So all in all, what you can remember is PD or T2 fat suppressed images are the ones that we mostly utilize in order to look for the contusions and also any pathology. Okay, so but just for the purpose of learning anatomy, the non-fat suppressed images also help us a lot in identifying structures, because now there's good enough contrast of the fat around these ligaments, because most of these ligaments are fibrocartilaginous or fibrous structures. So they appear very hypointense. Hypointense, when I say, it is like dark. So they will all appear dark on the MRI images. So we wanted to stand out against the bright contrast of the surrounding fat. So that's why I will be showing most of the structures on these non-fat sat images today, just so that you get an idea on how will the structures appear and where to identify, where to look for these. Okay. So we will follow a compartment approach to be able to see all of the structures. We'll follow the medial, lateral, central, and anterior compartment. So for each of these compartments, we'll first look at the bones. Then we'll follow an inside-out approach. So the innermost structure that we see will be an articular cartilage. Then we'll talk about the meniscus and the meniscofemoral ligaments which are attached to it. Then the cruciates in the central compartment, then the capsule and the extracapsular ligaments, and so on and so forth. So just very briefly, I am sure all of you are very well aware of all of these things, but still just as a brief recap, what is the knee joint is the largest joint in the body, and it is composed of 3 bones. One second. Formed by the distal end of the femur and the proximal end of the tibia, forming the tibiofibular joint, tibiofemoral joint, which is a hinge joint, again causing flexion extension and minimal amount of rotation. Then there's other joint, which is the patella, between the patella and the femur, that is the patellofemoral joint, again a planar type of synovial joint. That is why we can see that all along the articular surfaces we have hyaline cartilage lining it. So this forms the complex knee joint. Besides that, whenever we assess the knee joint, we also get to see the proximal tibiofibular joint as well. So the component of the femur is the medial and the lateral femoral condyle, the medial and the lateral tibial plateau. And along the lateral surface, the roughened part is the epicondyle of the medial and the lateral femur. And just posteriorly and superior to that, there's another roughened area, which is the supracondylar ridge. So all of these structures will give attachment which we'll identify on MRI subsequently. Okay, so first, before we go to the to each of the structures, just a few words about specifically the menisci. So the menisci are fibrocartilaginous structures. They allow better distribution of the femoral pressure. So we'll just grossly see a little bit of schematic, then I'll show the same on the image. So this is the medial meniscus, and this is the lateral meniscus. So we can see that the medial meniscus is more of a open, like a C-shaped structure, while the lateral meniscus, on the other hand, is more of a closed ring kind of a structure. So each of these menisci will have attachment to the tibia in the form of roots, that is the anterior root and the posterior root of the lateral meniscus, the anterior and the posterior root of the medial meniscus. In each of these menisci will have an anterior horn, body, and a posterior horn, anterior horn, body, and a posterior horn. Now, talking about little bit of a microstructural component, the peripheral part of the menisci are thick, that we all know, and it just thins out centrally, right? So the majority of this peripheral portion of the menisci is composed of longitudinal circumferential bundles. And there are some interspersed radial short collagen bundles as well. The significance of this circumferential bundle, specifically in this peripheral region, is it helps in the formation of the hoop strain. I'm sure you all must be knowing that whenever there is axial loading across the femoral bone, we can see that the articular surface of the femur and the articular surface of the tibial plateau is not very congruent like how we see in other joints. So, but placing this meniscus in between the two makes the articulation way more congruent now. So it articulates very well with this part of the meniscus. So the shape of the meniscus is also very significant, maintaining the stability. And along with that, like I said, whenever there's an axial loading, this axial load is transmitted via the meniscus, converted into a tensile stress known as the hoop strain, which gives rise to better weight distribution. So it's important that, and that is brought about these peripheral circumferential fibers. And if due to some radial tear or a root tear, this is torn, then that will give rise to meniscal extrusion. This hoop strain will not be created. The better weight distribution is again terminated there, and which leads to further loading on the articular cartilage, giving rise to early osteoarthritis. That is one thing, right? So that's why the importance of meniscus in here. This image I have just put to just get one concept through, that we don't really need, you can simply ignore all these numbers. What we need to remember is that the lateral meniscus is one structure which is not very tightly bound to the capsule. It is loosely attached to the capsule, and hence it has got greater mobility, unlike the medial meniscus, which is shares a quite intimate communication with the joint capsule, and hence it is less mobile and more prone to injury. One thing. But also on flexion extension, there is translation of these meniscal structures. So what happens is the lateral meniscus, all of it as a single unit, gets displaced anteriorly. On the other hand, the medial meniscus, it's only the anterior horn that gets displaced, while the posterior horn remains more or less at the same point, again making it the least mobile portion, and hence the most prone to injury. That's why we see posterior horn of medial meniscus tears way more commonly than the other sides. So this was one. I'm sure everyone's aware of this, but just a recapitulation of the same, that menisci are supplied from the periphery to the center, and hence the most peripheral portion is the red zone, the intermediate red-white zone, and the most medial, the free edge region, being the least vascular or the white zone, and hence again prognosis in the healing portion. So, okay, now coming to the appearance of meniscus on MRI, we should remember one thing. So I'm sure you don't want to learn too much about these terminologies on the physics of the MRI, but one thing we can remember is that lower TE meaning, just remember lower TE sequences are examples is PD and T1, but more importantly PD, because that's more commonly utilized. On PD weighted images, they are way more sensitive to detect meniscal tear, but they're less specific, because erroneously also we may see some abnormal signal sometimes. But the higher TE, that is T2 weighted sequences, are more specific. So there may be some tears which may be missed on T2 weighted images, but it will be seen on PD weighted. But once you see on PD, it may not actually be a tear also. So this is just something that you should remember, that PD weighted sequences are way more sensitive than T2 weighted sequence. So now okay, one more thing that I wanted to tell before we go and see the image on MRI is that, so this is, everybody knows the anatomy of menisci, which looks like this. But on MRI, when we try to image and see, we'll not see like this, right? This is the kind of appearance that we may see if we have a section passing through the meniscus like this, that is on an axial scan. So on an axial image, if we are lucky that the section crosses just exactly through and through the meniscus, then we may get this appearance again like this. But on sagittal and coronal images, when we try to visualize the meniscus, it will depend on how the section is taken. So sagittal is when we'll take sections like this, right? So when we are taking one section sagittally, in the most peripheral portion, this will pass through the thicker part, only the thicker part of the meniscus, and hence it will look on the cross section more like a rectangular box. And as and when we go more centrally, we'll see thicker peripheral portion, centrally thinned out, and again thicker portion. And once we take a section most medially, then we see only the thick central, no meniscus, and then in the periphery meniscus. Okay, so that's how you have to imagine how the section is taken. So sagittal is one of the most important sections that we assess when we are looking for meniscal injury. So I'll just show how it will appear like. And in the, yeah. So you can see that whenever we are looking at MRI, we always want to open the sequence that we want to assess, and also another sequence in the orthogonal plane, just so that we know whether we are seeing medial or the lateral. because sometimes it can get very confusing. That's the reason why I've opened both of these together. One axial, which will show this is the fibular head, this is the tibia. So we know that this is the lateral aspect and this is the medial aspect. Because as soon as I open this, if I open just this, you will not be sure whether you are dealing with the medial aspect or the lateral aspect. Although there are some clues which I will tell, which will tell us that okay, now you are looking at the medial aspect or the lateral aspect. But if you're just simply shown some image like this and told that okay, you know that this is the meniscus, this is posterior horn, anterior horn, but whether it's medial or lateral, you will know. So most of the time we always correlate. We open two images together and see this section. This is the green is showing where the section is taken from. So this is the medial meniscus, this whole round thing, and this is the lateral meniscus. So if we see the section is taken through the medial meniscus, then that's how we can correlate. But there are some other clues, like I'll tell you right now. One is that, so in the sagittal image, we can clearly say that this is the femur, this is the tibia, anteriorly we have the patella. So if we see the shape of the tibial plateau, if it is very symmetrical and it appears like a pin of a golf, something like, if you see this kind of a shape, golf pin, this shape of the tibial plateau, that means that we are on the medial aspect of the joint. So you can now see this shape resemblance. This means that now we are looking at the medial tibial plateau. So medial tibial plateau will give attachment to, of course, the medial meniscus. So these very hypointense dark things, these triangular structures anteriorly and posteriorly are medial menisci. And how will we know which part is? Again, if you correlate and see on the axial image. So this is one of the most peripheral section. Okay, so if we see here, so on the axial image, we can see that the section is taken. This is the medial meniscus. This is the tibial meniscus over the tibial plateau. If we take a section through this area, then we are seeing this is the femur. This is part, little bit part of the tibia that is visible. This dark structure is the meniscus. So we can see a part of the anterior part and the posterior part of the body, and still some section taken through the middle or the red white zone of the meniscus. That's why we're seeing it as a continuous bow tie. Okay. And if we go further medially, then we start seeing it as menisci as triangular structures. So this is the anterior horn of the medial meniscus. This is the posterior horn of the medial meniscus. Meniscus will also always be seen as peripherally thick and thinning out centrally. So again, like how we discussed earlier, it will be seen as this part is the free edge on the of the anterior horn and the posterior horn. So this is the white zone. This is the intermediate portion, the central portion, which is the red white zone, and the most peripheral portion of the meniscus is the most vascular part or the red zone. So one thing that we can notice about the medial, so we have already started seeing the medial compartment, all right? So in the medial compartment, we see that this is the anterior horn, this is posterior horn. The posterior horn is almost twice the size of the anterior horn, and that is normal. On the medial meniscus, the posterior horn is always supposed to be larger than the anterior horn, almost twice the size. And if in case when you're looking at the medial side and you notice that the anterior and the posterior horn are almost of the same size, that means that it is an abnormal meniscus, and you have to look for a tear. Maybe there's truncation tear of this tear of the free edge area, that's why it's appearing small, or some part of it is broken and it must have been displaced. So you have to start, in that case, you have to start looking for the broken part or the torn part of the meniscus somewhere else. And second possibility is that you have to ask the patient if he has undergone any meniscectomy in the past, because of which the posterior horn is appearing small. So this is one indication. So this is about the meniscus. Yeah, it will look like this. So we have seen this is the body, the most lateral, most medial aspect. You'll see the body and the anterior and the posterior horn. And as we go more and more medially, we see the attachment, or that is the root of the medial meniscus. This is the anterior root. Now we can see that this has attached to the tibial plateau. On the posterior aspect, I'm coming medially back again, and if we trace it, it's going and attaching eventually to the tibial plateau. And the posterior horn or the posterior root of the meniscus attaches anterior to the posterior cruciate ligament. So that is one landmark you can remember. Now, other structures in the medial compartment. So let's just finish the medial compartment for now. So one thing is we've already discussed the meniscus, but before that we'll just see the bones as well. This is the medial femoral condyle. This is the medial tibial plateau. These dark line, irregular line is nothing but the physeal scar. This is the site of the physeal closure. And what we have to see is if the articular margin is smooth or not. And in bones, are important that we look for any contusion pattern, because that can be a hint to any injury. Those are the indirect signs for injury. So where all do we typically see, especially in the medial compartment? If we see any contusion in the posterior aspect of the tibial plateau or the anterior aspect of the femoral condyle. Most importantly, this region. Okay. So yeah, these two corresponding regions, which are commonly seen as contusion in pivot shoot or the twisting kind of injury. In the and subchondral location, we have to look for edema. Another thing that we can see is the articular cartilage. So because knee joint is a weight bearing joint, so obviously the cartilage of the knee joint would be should be quite thick compared to the other joints, the non weight bearing joints. What does the cartilage look like on an MRI is that it will be of an intermediate signal. It will not be as bright as the fat, and it will not be as dark as the meniscus or the fibrous structures. It will be just intermediate signal. So we know that this is the articular surface. So if you see, can notice that this thin intermediate signal structure just overlying the articular surface all the way there, that is the articular cartilage of the femoral condyle. And this again intermediate signal intensity structure along the tibial plateau is the articular cartilage of the tibia. So this is not a cartilage specific sequence. These days we have got various GRE type cartilage specific sequences where the cartilages are better seen and they stand out, and we can easily tell how much thickness, or if there's a full thickness there, or if there's a partial thickness there, or if there is an associated cartilage defect with an underlying bone change. Okay, so that's one thing. Now we have discussed earlier, okay, that medial meniscus has a very close relationship with the medial capsule, right? So we can see that if we try to trace and see the medial meniscus, the periphery of the meniscus is, you can see these thin fibers going from the meniscus to the periphery. So this whole area is nothing but the capsule of the medial joint compartment. So these fibers which are extending from the meniscus to the capsule are also named by many people as the meniscocapsular. So the ones that are going towards the femur will be meniscofemoral, and the ones directed towards the tibia, meniscotibial. So these are meniscofemoral and meniscotibial ligaments that are extending from the meniscus all the way to the capsule. And tear, especially of this is the posterior horn, tear of the meniscofemoral, meniscotibial ligaments are the ones which are responsible for meniscocapsular separation. So on the medial meniscus, remember that it has the menisci are closely opposed or closely adhered to the capsule. And if there is any tear to these ligaments, then there can be further meniscocapsular separation. There can be fluid signal in between the capsule and the meniscus. Especially, we have to look in the least mobile portion of the meniscus, which I explained earlier, that it is the posterior horn of the medial meniscus. So it will be this region. And this is exactly where the ramp lesion also occurs. Okay, so that's why the significance of looking for the posterior horn of medial meniscus and its relationship with the capsule overlying it. Okay, then we'll talk about the corners later. Then now this was the medial compartment menisci. We'll move to the lateral compartment. So like I said, in order to identify the site okay, or the side, whether it's medial or lateral, we have to look for the shape of the tibial plateau. So this is the lateral aspect. Now you can see the shape is not looking like a golf pin, like I said earlier for the medial. This is looking more like, you can see that the posteriorly it is projecting further. And if we imagine an inverted L shape here, then it, yeah, the shape is looking like an inverted L. So L for lateral. That's how you can remember that when you see the shape of the lateral tibial plateau, shape of the tibial plateau in the form of an inverted L, then we are looking at the lateral aspect of the joint. Okay, so again, we're seeing the lateral femoral condyle, lateral tibial plateau, the physeal scar, and the bones. So again, same drill, we have to look for contusion patterns, posterior part of the lateral tibial plateau, and the anterior superior part of the medial femoral for pivot shift. This area specifically, so you can see again the lateral menisci. If you see the meniscal margin, so this area of the lateral femoral condyle just superior to the anterior margin of the anterior hornomedial meniscus, this area is known as the sulcus terminalis. And in commonly in ACL injury, this is the area which undergoes some impaction fracture. There can be a depression right at this location, and that is like popularly known as the lateral notch sign. So we have to look for any edema in this region, or if the contour of the bone, if there is any depression or a defect here, that is the sulcus terminalis involvement. So like on the other side, like how I showed the articular cartilage as this intermediate signal intensity, this is the lateral femoral articular cartilage all along the femoral condyle going up. So some people divide this articular cartilage further into a weight bearing and a non-weight bearing portion. The weight bearing portion, how do we know which part is the weight bearing portion? Is the cartilage which is just in line with the anterior and the posterior margin of the meniscus. So this whole area is the weight bearing portion of the articular cartilage, and this is non-weight bearing portion. And some people further divide it into anterior, middle, and posterior in order to tell the finding that, okay, I see there's some partial thickness defect in the central portion of the weight bearing articular cartilage. That's all. That's the only significance. So similarly, this is the articular cartilage lining along the tibial component. So you can now easily tell. Yeah, and one more thing that you can notice over here is that, like I discussed earlier, that the articular surface of the femoral condyle and the tibial plateau are not necessarily very congruent like we see in other joints. And that's why the significance of this shape of the meniscus, which further increases the congruity between the two, and hence a better weight transmission across this bone. Okay, so the assessment of the lateral meniscus is exactly the same as how we did for medial meniscus. Again, you go in the periphery. That time, initially, the meniscus will look like a rectangular structure. And as we go more and more towards the center part of the meniscus, we'll start to see this bow tie appearance. And as we go further medially, we'll see these triangular structures which are thinned out, getting thinned out towards the center, and the peripherally they're thick. Okay, so when we assess the lateral meniscus, one thing that we have to always keep in mind is to look for a discoid meniscus. Discoid meniscus is when these menisci, instead of being a C shape, they will be in the form of a disc. So instead of thinning out centrally, they will remain thick even in the center. So how do we diagnose a discoid meniscus? Is on a sagittal image. So we just see that in the first section, in a rectangular appearance is normally also seen. In the second image, it starts to thin out. And by the third image and the fourth image, for sure, we'll see only these triangular structures. But in a discoid meniscus, even after the third section, we'll still see a continuous bow tie. Or maybe a simple rectangular structure. So that will be suggestive of a discoid meniscus. And the same thing if we see in a coronal image. So in the mid-coronal section, again, the meniscus will appear as a triangular structure with the thicker portion in the periphery, and thinner central portion. But in case of a discoid meniscus, instead of it being thin here, it will be rectangular all the way up to the center. So we can simply measure it from this margin till the margin that it is seen. It should not be more than 14 millimeters. So if it is more than that, then it is a suggestive of a discoid meniscus. And why? Specifically because it's more common in the lateral aspect. That's why we have to more commonly look for, think of discoid meniscus, rule out discoid meniscus on the lateral aspect. Why is it important is, there may be many people who have discoid meniscus and have no symptoms. That is all right. It's just that, like how we discussed, the shape, particular shape of the meniscus is so important in the proper weight transmission. So if it loses this shape and it becomes discoid, then the hoop strain formation will not occur, and hence the proper weight distribution will not occur. Hence, the biomechanical properties will be lost, and that's why it is more prone to tear. That's why. Okay. So that was about the lateral meniscus and the lateral aspect, articular cartilage. Now, along with the meniscus, we will look at two other things. The menisci also give attachment to the femoral part of the condyle, that is known as the meniscofemoral ligaments. You must have heard of these terms, meniscofemoral ligaments. So as the name suggests, you just have to follow it from the meniscus to the femur, and this happens from the lateral meniscus. So this is the lateral meniscus, and if we follow it more medial sections, in the more medial sections, we'll see that there is one thin structure, this thin structure, which is going posterior to the posterior cruciate ligament and further attaching to the medial femoral condyle. So yeah, always try to follow a structure in the sequential images. So if you get confused, then you can always use another section, another orthogonal plane in the opposite area, and then see. Now I am on the medial side. This is the lateral meniscus. You can have a look here. I'm going more and more medially. So as I'm going more medially, we can see that from the meniscus is going anteriorly, but some dark structure has extended from the meniscus going more posteriorly. Again, in the next section, you can see this is a PCL, and just posterior to the PCL, this band is extending, further extending. I'm going more medially, and then it's going up and attaching to the, this is the medial femoral condyle. So attaching to the medial femoral condyle. So it has started from the meniscus and going to the femur. So meniscofemoral ligament. There are two meniscofemoral ligaments which arise from the lateral meniscus and attach to the lateral meniscus. Start, okay, it will attach to the femoral condyle. There are two of them. One is the Humphrey, one is the Risberg. You can remember the names as H for Humphrey. H is the alphabetical letter which comes earlier, so it will be anteriorly. Risberg, W-R-I-S-B-E-R-G, Risberg, so W, that's why posterior. So it will be, both of these ligaments are either anterior, one is anterior, one is posterior to the PCL. Both may not always be seen, but most of the time it's seen. Like in this patient, the Humphrey is not very clearly visible, but the Risberg is. So, and Risberg is the one which is of more significance as well. So this is one thing, one structure that we should be able to see. Risberg meniscofemoral ligament. So it is just posterior to the posterior cruciate ligament. Why is it significant? Is because now you see at this point, this is a meniscus, this is the Risberg ligament. And as we go medially, it may not have still attached completely. So sometimes some people may think that this is a tear. If there is, the black continuous black signal is not maintained. So some people confuse this Risberg attachment as a tear. But if this abnormal signal extends further more medially, then again, it is an abnormality known as the Risberg rip, which we'll discuss later once we start discussing the pathologies in the subsequent lectures. But right now, for now, you should just remember that from the lateral meniscus, posterior horn, we see another ligament, thin ligament extending from here, and going posterior to the PCL. And that is a normal structure. Okay. So, yeah, like I explained to you, when you are suddenly given a sagittal image, whether to say it's medial or lateral, you look at the shape of the tibial plateau and decide. Similarly, there's another hint to the same, whether we are on the medial or the lateral aspect. If you're given a coronal image, wherever you see the fibular head, obviously that is the lateral, so that's how you can identify. But if it is slightly in the anterior aspect, then also we will be able to tell which side is medial, which side is lateral. That is by looking at the femoral contour. If we see these groovy, irregular contour compared to the smooth opposite contour, this is always on the lateral aspect, and this smooth contour is always on the medial aspect. Why is it so? Because the femoral condyle gives attachment to the popliteus tendon, and also from the superior portion, it will give attachment to the lateral collateral ligament, and that's in the form of a groove. So this is also another way to identify whether we are on the lateral or the medial aspect. So this is now we know that this is the lateral aspect. This is the lateral femoral condyle. So that is one way to identify the structures. Okay, so we have discussed the medial and the lateral compartment. There's one, okay, we'll first just follow the compartment wise approach. Now we look at the central compartment. Central is, if we can see here, so anteriorly we have the lateral and the medial femoral condyle. And as we go slightly in the posterior section, we can see that these two are separated by a large groove or the intercondylar fossa. So this is the central portion of the joint, and corresponding to this intercondylar fossa, on the tibia we have the intercondylar eminence. This is the intercondylar eminence, and normally we should be able to see only two structures in the intercondylar fossa, that is the anterior and the posterior cruciate ligaments, and rest of it is filled with just simple fibrofatty tissue. So if we see anything other than these two, then it is abnormal. So whenever there's some bucket handle tear where there's longitudinal tear of the meniscus and it gets displaced, then we'll see it in the intercondylar fossa here. So that will be an extra structure other than the ACL and the PCL. So rest of it should only be filled with fat. So this is one thing you can remember. So right now in this patient, all I can see is one structure here, another structure here. So this is the ACL, this is the PCL, there's nothing else. So that means we're good. Okay, now the most important component of the central part of the joint is the ACL and the PCL, and the attachment everybody knows, I believe. So anyway, just to recap, it is ACL will have a tibial attachment and a femoral attachment. The tibial attachment is on the intercondylar eminence, and it goes and attaches to the lateral femoral condyle medial aspect. So ACL, PCL are the most important stabilizers, especially for anterior and posterior, to avoid restraint of the anterior posterior translation of the tibia. Now, how a normal ACL should look like on an MRI is the question. So if you see in a sagittal image, the ACL, this is the anterior cruciate ligament. Anterior cruciate ligament will always have an orientation which is parallel to the Blumenset line. And what is this Blumenset line? Is nothing but the roof of the intercondylar fossa. Okay, so we can see that this is the roof of the intercondylar fossa, and this is the roof, this Blumenset line, and the orientation of the ACL should be parallel to that. And ACL fibers in extension, because we do all of these MRI imaging in the extension position. Patient is always lying supine. So in extension, it should be taut. So you can see that these fibers are taut. We don't see any laxity. It's just straight fibers. And it is parallel to this Blumenset line. So it is normal. And one more thing to remember in ACL is that if I show you a non-fat fat suppressed image, near the tibial attachment of anterior cruciate ligament, I'll show in both the images. So this is a sagittal image, this is a coronal image. Okay, we'll see both together. So this is the tibial attachment. This is the tibial attachment of the anterior cruciate ligament fibers. These are the fibers. So because it's made up of multiple fibers, which may have some synovial tissue going in between the fibers. Okay, so ACL and PCL, remember, is a extra synovial tissue. it is intracapsular, but it is still extrasynovial. Okay, so we may get some synovial tissue trying to project in between the fibers, and hence the normally also near the tibial attachment we may see some hyperintensity, but that is normally seen. So this should not be confused with a tear. For to be able to label something as a tear of the ACL, we should be able to see the some of the direct and indirect signs. Direct signs being like complete disruption of this fiber, and it will lose its normal taut appearance. It will become lax. The orientation of the ACL will be lost, like how this is taut and parallel to this Blumenfeld line. It will be, if it is torn, then it will have a very flattened appearance, like it's just slumping here. Okay, so, and yeah, like in the coronal image also, we can see this is the tibial attachment. We can see the corresponding on the sagittal. This is the tibial attachment of the anterior cruciate ligament. And as we trace it posteriorly, we can see the fibers move and go and attach to the medial surface of the lateral femoral condyle. This is the femoral attachment of the anterior cruciate ligament. This is how it will appear. And on the sagittal image also, we can see it go and attach to the femoral. So these are the rest of the fibers of the ACL. Again, whenever you have doubt, because this is a fat suppressed image, like I said, there will be two structures in this intercondylar fossa and rest of it is fat. Because the fat is suppressed, even the suppressed fat appears very dark. So you can get confused in such cases. It's always a good idea to correlate with the non-fat suppressed image as well. Like in this case, now you can see that this area and this area is just the fat which is next to the cruciate ligament, and it's nothing to worry about. This is not something abnormal which we may get confused on the coronal image. So this is the appearance of ACL. And now we always study that ACL is constitutes two separate bundles together. So there's an anteromedial bundle and a posterolateral bundle, and many times on imaging you will be able to tell which one is anteromedial, which one is posterolateral. That you can correlate on a axial image. It's better seen that way. So this is a again axial image in the intercondylar region. So, and yeah, this is lateral femoral condyle, there's a medial femoral condyle. So what structure will come close to the lateral femoral condyle is the anterior cruciate ligament. So this is the anterior cruciate ligament, and this is where the cruciate ligaments are attaching. I can show in one non-fat sat image that we will be able to tell better. So now, okay, this is better now. Just remember, this is of a different knee, so different person. That's why the side may be different. Okay, so this is the lateral aspect. We can see the fibular head here. I'm just using this other patient just so that you're able to see the ACL two bundles separately. Okay, because I didn't have a non-fat sat image of the other patient. So yeah, this is the lateral femoral condyle. So whatever structure comes closer to the lateral femoral condyle is the anterior cruciate ligament. So you can see that this whole dark thing is the anterior cruciate ligament. This is the posterior cruciate ligament. Anterior cruciate ligament, we can see that there's vaguely two bundles, one bundle here, one bundle here. When we say anteromedial and posterolateral, anterior and posterior is determined by the position on the femoral condyle. So on the femoral condyle, we can see that this is anterior and this is posterior, right? So this is posteriorly attached, this is anteriorly attached. If we follow this anterior bundle, yeah, it's going more medially. So these are the anteromedial fibers of the anterior cruciate anterior cruciate ligament, and these are the posterolateral bundles. Why is it important? Why am I showing this? Is because many times patients may have injury to only the anteromedial or the posterolateral bundles, and we have to report separately and tell specifically that it is the anteromedial fibers that are torn or the posterolateral bundles. So the easy way to identify which one is which bundle is what I find is that you look for its attachment on the medial femoral, lateral femoral condyle. Whatever is anteriorly attaching, that is the anterior medial. What is posteriorly attaching is the posterior lateral fiber. And just follow them inferiorly like this. Okay. And within the same, you can see very nicely that close to the lateral femoral condyle is the ACL, and close to the medial femoral condyle, you are seeing the PCL fibers panning out. Okay, so we were looking at the ACL and PCL. We'll go back to the original patients just so that there is not much confusion about the sides. So now we know how will a normal ACL look like, and PCL, posterior cruciate ligament, always appears completely hypo-intense or completely dark on most of this, almost all the sequences, unlike the anterior cruciate, which may have the striated appearance in the tibial attachment side. Posterior cruciate ligament will always appear completely dark in its whole extent, like this. It will always appear a little bit lax compared to the anterior cruciate ligament because it will become taut when the knee is in flexion. But here the knee is in extension. Whenever we do MRI, mostly the knee is in extension. That's why the PCL will always have this appearance, slightly lax appearance, but purely hypo-intense thick band. And most of the time PCL is not injured. ACL is way more commonly injured than PCL. So this is about the central compartment. Now we'll talk about the anterior aspect, anterior compartment of the knee joint. Anterior compartment has the patella. Patella is attached, is basically a sesamoid bone within the tendon of the quadriceps. So technically speaking, the quadriceps tendon is extending all the way to the tibial tubercle. But what we call this portion as the quadriceps tendon, then the patella, and then the portion which is below the patella is known as the patellar tendon, or some people call it the infrapatellar ligament. So either way, the quadriceps tendon as well as the patellar tendon should be again hypointense on all sequences because these are tendinous structures, so it should be like completely dark. But we may see some striations. But if there are some hyper intense signal, like very bright signal within the patellar tendon, especially near the patellar attachment site, then that could be indicative of jumper's knee. So you have to look for those things. Quadriceps tendinosis is quite common in older patients. Okay. And in the anterior compartment, what we see below this is the patella, and this is the patellar articular cartilage. Okay, and that is better assessed on axial images. We'll see on axial as well. But the trochlear patellar cartilage, patella articulates with the femoral trochlea, and this is the trochlear cartilage, which is divided into superior and an inferior portion, and better seen on axial image. Okay, so this thick intermediate signal intensity structure, you can see this intermediate signal intensity structure along the patellar facet. This is the patellar articular cartilage. So another way to identify again a medial and a lateral is, if you see the lateral patellar facet, it's always kind of elongated, way more compared to the medial patellar facet. Okay, so this is the lateral patellar facet and the overlying cartilage on it. This is the medial patellar facet and the overlying cartilage. And inferiorly, we get to see the trochlea. So this is the trochlea of the femur, which will articulate with the patellar cartilage, patella. So this is the lateral trochlear facet and the medial. So medial and the lateral again. Besides that, like I said, in the anterior compartment, other structures that we need to see is the fat pads. So I already told this is a non-fat site image. So the fat will appear like this subcutaneous fat. So if we see this is the patella, and just above that, there's this triangular fatty tissue, right? So that is the suprapatellar fat pad. We talk about suprapatellar fat pad impingement syndrome, where this fat undergoes inflammation, like there's inflammation of this fat pad, and it becomes thickened, prominent, and projecting posteriorly like this. This is the femur, and you can see there's another area which is completely hyperintense, just anterior to the femoral shaft. That is the prefemoral fat pad. This whole thing is a prefemoral fat pad. This is the suprapatellar fat pad. And in between the two fat pad, we can see this very bright structure that is nothing but thin fluid in the suprapatellar bursa. So suprapatellar bursa is not completely separate from the joint. In majority of the patients, suprapatellar bursa communicates with the knee joint. So whenever there is a knee joint, if you knee fusion, you'll always find some amount of fluid in the suprapatellar bursa. So that's very commonly seen and not necessarily pathological. Another fat pad that we need to see is this fat pad, which is seen below the patella, infrapatellar fat pad, also known as the Hoffa's fat pad. So this whole area is filled with fat, known as the infrapatellar or Hoffa's fat pad. What do we see in these fat pads is something called plica. Plica can normally be visualized, sometimes may be seen, sometimes may be completely absent also. And in some patients, rarely, it can get completely thickened and be pathological and be a cause of the pain as well. So you see these thin fibers, fiber-like structure, hypointense, extending from the inferior border of the patella and going and attaching finally to the intercondylar region, that is the infrapatellar plica. So, and here in this patient, the suprapatellar plica is not very well seen. And there's another two groups of plicae, that is the medial and the lateral. The infrapatellar plica is commonly seen. The supra is also commonly seen. Sometimes the significance is of majorly the medial patellar plica, which can get very thickened, and because of repeated friction, it can lead to some edematous change on the medial aspect of the knee over here, and where we'll see edema in the fat and the adjacent bones as well. And we can see a thickened plica. So that is the anterior, it's one of the causes of the anteromedial knee pain. There is a plica syndrome. And sometimes the superior or the inferior plica can also show similar changes. So in the anterior compartment, we have to look for the normal fat signal. If there is any abnormal edematous changes in the fat, that can lead to fat pad impingement. Then we have to see if the suprapatellar, if there is any fluid in the suprapatellar fat pad. And one more thing that we can see in the anterior part is the prepatellar. So this is the patella just anterior to that in the subcutaneous plane. If we have fluid signal or if there's inflammation, that will be suggestive of prepatellar bursitis or infrapatellar bursitis. Infrapatellar bursitis can again be seen as two different types, the deep and the superficial. So the deep infrapatellar bursitis will be seen as fluid and abnormal bright signal in the fat, infrapatellar fat in this region, or the superficial will be seen as edema in the subcutaneous plane just above the attachment site of the patellar tendon. So these are the things that you need to see in anterior aspect. So we have covered more or less most of the knee intricate structures. Now we'll see the corners followed by the muscles around the knee joint. So there are two corners that we always talk about, that is the posterior medial and the posterior lateral corner. Significance of identifying any injury to these corners is that many times they are associated with ACL injuries, and if we do not identify these, the patient can get a ACL reconstruction or repair done, but the cause of his pain is still there, right? So if that is not fixed, then it will lead to failed surgery. That's why it's important that besides the obvious injury, we should also look for these corners to not miss these injury to these structures which need to be surgically treated. So we know that this is the medial aspect, this is the lateral aspect. We'll start with the posterior medial corner. I have one or two schematic images which will help you in identifying the structures better. Okay. So in the posterior medial corner, there are so many structures which people talk about, but it's actually very difficult to see each of these structures on an MRI and identify and then tell that there is an injury to it. So just have a brief overview of these are the named structures and where do I look for it, and if there is an abnormality, how will I know that if that structure is injured? So there are various structures which are constituent of the posterior medial corner, but just remember one thing. It's very simple, that on the medial, so it has to be something to do with the medial compartment. So medial collateral ligament is there, and anything that is seen posterior to it. So anything that is seen posterior to the posterior margin of the medial collateral ligament, all the way up to the medial border of the posterior cruciate ligament. So all of those structures that you see in that area you may not be able to tell each and every structure separately, but that area is where the posterior medial corner lies. So just remember, it's POL and OPL. POL is nothing but the posterior oblique ligament. OPL is oblique popliteal ligament. So just you can remember simply the names. They come in this sequence, POL and OPL. Okay, that's how I learned that just behind the MCL, there is POL and OPL. And then you will have the posterior cruciate ligament. So there are some extra reinforcements. These are nothing but thickening. You can say there's a thickening of the capsule, or just superficial to the capsule. There is some fibrous thickening. Another important structure in the posterior medial corner area is the semimembranosus tendon. So that also one more thing that you have to just simply see, because that is pretty obvious. I'll just show an MRI. It's very easy to identify the same. It's just that we always study of semimembranosus as some tendon that ends at the posterior proximal tibial plateau, but it's not necessarily like that. Majority of it will end at the proximal tibial plateau, but it will give these thin expansions in and around, and that's why it is a part of the posterior medial corner. Okay, so these are just a few structures that you need to see. So like I said, briefly, you just need to remember anything that is between the posterior margin of the medial collateral ligament and medial margin of the PCL. Just have to identify these two structures. Anything that you see in between the two is the posterior medial corner. Okay, so I'm just showing this other patient where the non-fat side image is present. So now just don't get confused. This is the medial aspect. This is the lateral aspect. This is a different patient. Okay. So, and this is the femur, medial condyle, lateral condyle. So medial epicondyle, you see this thin band-like structure? That is the medial collateral ligament. And just posterior to that, and this is, okay, first identify the medial collateral ligament and identify the posterior cruciate ligament. Or maybe I'll just open in the other patient only, otherwise you'll get confused with the sides. So just identify these two structures, and whatever you see in between the two will be the posterior medial corner. Okay, it's already 8. I'll not take long. I'll quickly show. Okay, back to the original patient, so no confusion. Okay, so this is the medial, that is the lateral. Okay, if we see proximally, this is the femur and this is the femoral epicondyle. And this structure that is arising from here is the medial collateral ligament. So anything that is just behind the medial collateral ligament, and on this side, we have to look for the posterior cruciate ligament. So this is the posterior cruciate ligament. Anything in between these two is nothing but the posterior medial corner. Okay, and here, yeah, so this is this structure, dark structure that you see, which is just superficial to the femoral condyle bone part, and you will see this structure. This whole thing is nothing but the posterior oblique ligament and oblique popliteal ligament. And we talked about the semimembranosus. The way to identify semimembranosus is you just have to go proximally in the distal thigh region. You'll see this really round big muscle and a tendinous structure lying just on top of it. So this is the configuration to identify the semi-membranosus and the semi-tendinosus lying on top of it. So simply you have to follow the same inferiorly. We can see that this is a semi-membranosus becoming more and more tendinous. And just adjacent to that, this is the medial head of gastrocnemius muscle and the tendon. So between these two, this is the site for the popliteus or the Baker's cyst that we commonly see. So as we see that the semimembranosus is going down, majority of it is attaching to the proximal tibia, and then it gives these different expansions which will go inferiorly along the medial aspect. So this is, you can see it is in very close proximity to the posterior medial corner that I said. So that's why the semimembranosus is also an important component contributor to the posterior medial corner. So if whenever you see this area, if there is any edema or fluid signal in this region, that is suggestive of injury to the posterior medial corner. And this is also close to the posterior horn of the medial meniscus. And that's why, again, another site which is very prone to injury. Okay. So I'll quickly show the collateral ligaments now, and then I think we've covered most of the things that way. So collateral ligaments are best seen on coronal images. Remember that. So this is the medial aspect. This is the lateral aspect. Again, we can see a very thick band arising from the medial epicondyle and extending inferiorly. So this is the medial collateral ligament. Some people say that there are two bands, superficial and a deep component. So this major thick one is the superficial component, which goes inferiorly 5 to 6 centimeter distal to the joint line and attached to the tibia. While the deep component is the one which gives integrate attachment to the meniscus. That's why I said the medial meniscus is closely attached to the capsule. So the deep portion of the medial collateral ligament it blends with the capsule and also blends with the peripheral part of the medial meniscus, and hence it is less mobile. This is the superficial part of the medial collateral ligament, which goes inferiorly all the way up to the tibia. This is the medial collateral ligament. The lateral collateral ligament, the way to identify, like I said, on the lateral femoral condyle, we see these projections. We just have to look for, okay. We can see that this is the superior projection. We can see a thick band which is extending from the lateral femoral epicondyle all the way down to this is the fibula. So all the way down to the fibular head. That is the lateral collateral ligament. And what happens to the lateral collateral ligament inferiorly is that it blends with the tendon of the biceps femoris to form a conjoint tendon. So this is the muscle of the biceps femoris, and inferiorly we have the tendon which fuses with the lateral collateral ligament to form the conjoint tendon and attach to the fibular head. Okay. On the lateral aspect, if we come way more anteriorly, we can see that there's another band which attaches to the tibia instead. This is the lateral tibial plateau. Okay, and this is nothing but the iliotibial band. So how to identify the iliotibial band separate from the lateral collateral ligament is that you see the distal attachment. If the distally it is attaching to the tibial plateau, then it is iliotibial band. And if we see that there's structure which is arising from the femur and attaching to the fibular head, that is the lateral collateral ligament. All right, and yeah, that's pretty much it. And one more thing you can identify on an axial and on the lateral aspect is the popliteus muscle and the popliteus tendon. So you can see this is the tibia. Just posterior to that is this muscle bulk of the popliteus, and if this is the tendon of the popliteus, as we go superiorly, it is going laterally and further laterally to go and attach to the fibula, which on an so popliteus tendon is one thing which pierces the capsule and becomes intracapsular and attaches to the lateral femoral condyle. And the place where the popliteus tendon crosses the lateral meniscus forms the popliteus hiatus, and that can be confused as tear many times. So this is one thing that we have to keep in mind, that on the lateral aspect, in the lateral meniscus, so if you can see this is the lateral meniscus. You can see the thin fibers going posteriorly, and if we follow it, we can see, Okay, I don't know if you're able to appreciate. This is nothing but the popliteus tendon, which is coming from the posterior aspect, going all the way laterally and to attach the femur. So, and it is crossing very closely to the posterior horn of the posterolateral part of the lateral meniscus, and there is some space in between the two. That is nothing but the popliteal hiatus. So this on the lateral aspect is normal. On the medial aspect, if you see some fluid signal like this, then it is abnormal. On the lateral, it is normal because this is where the popliteus will enter the capsule to become intracapsular. And this is where the popliteus hiatus is. So it can have that fluid signal. So this is just one thing that you need to remember. Okay, finally, posteriorly, one thing that we'll see is the popliteal vessels and the nerve, popliteal vessels and the nerve along with it. So in the more proximal sections, we can see this is the posterior tibial nerve and this is the common peroneal. And as we go inferiorly, we can see that the two have separated and posterior tibial will continue along with the popliteal vessels, while the common peroneal, this is the common peroneal, it will go laterally and become more and more superficial to come just under the skin and in the subcutaneous plane, and inferiorly it will cross and around the fibular neck. Yeah, I think we have covered almost all the structures in the knee. I hope you remember better. Okay. Yeah, that's it.
Yeah, thank you. Thank you so much, Dr. STANZIN, for such an elaborate presentation. And I'm sure, like, at least I don't remember having attended such an elaborate session ever before, and that too by such a dedicated musculoskeletal radiologist. So it's definitely our privilege, and I must say, we are so fortunate to have you today as a speaker for this musculoskeletal radiology webinar. And I think with this background, your subsequent lectures and the series which we're going to follow, that will make our job pretty easier to understand the pathologies, which definitely will be covering up more in detail.
Yes, sir.
And if I could just ask a couple of questions, quick, just for sake of discussion. Like we do come across different types of MRIs in terms of Teslas, so like 1.5, 3 Teslas, and also, and there is a kind of a feeling like greater the Tesla, the better is the quality. So is it like, does it really matter? And
So
what do you suggest?
So if we want to see very thin structures, like suppose say the arcuate ligament on the posterolateral corner, then maybe a 3 tester would be beneficial. But it's not necessary, sir. If some trained radiographer is sitting on the console and acquiring the case, then we sometimes, most of the times, we get as good image on a 1.5 Tesla also as that of a 3 Tesla. So yeah, the images are more smooth, there is better contrast and stuff, but the things that we need to see, we are able to see just fine on 1.5 Tesla also, as long as it's acquired properly. So there's a lot of importance that we place in the acquisition of the MRI for especially for musculoskeletal radiology.
So can we conclude like that for most of our requirements, 1.5 Tesla is more than sufficient?
Yes, for most of the common indications in larger joints, definitely I think 1.5 is good enough. But for smaller joints, like in the wrist, or if you want to look for those, look for finger in, like do imaging of the finger, and if you want to look for very small ligaments, particularly in intricate like smaller joints, then 3 Tesla may be better. But for all practical purposes, the gross things that we need to see, all of it is visible on 1.5 Tesla as well, if acquired properly.
Yeah, great. So just one more question, like, if somebody as a orthopedic surgeon, I must say, and not as a radiologist, definitely you have got access to everything. but like as we see, we usually get the films, static films.
Mhm.
So how do you suggest? I mean, one should go for like getting the MRI films in the CD form and then trying to run
Um,
it over your laptop,
a
because I think
viewer,
that is more interactive.
yes, if you
And
have a viewer in your laptop, then best is to assess the images on laptop on a viewer. But if you do not have access to that, sometimes patients do not bring CD, they only have films, then we have no option but to go through the films. So you want a few things you can remember is, like I said, like using those clues, that the shape of the tibia and the patellar articular cartilage, the contour of the femoral condyles, you can get a better idea about which side you're looking at. And by convention, the filming is always done from the medial to lateral aspect. So that also you can keep in mind. And it, for a coronal image, it's always from anterior to posterior. So you can get an idea that way. And you should look for those bony landmarks that you know for sure are anterior. So whenever you see a coronal image, if you see the patella at some place, then you know that that is the anterior part of the sequence. So that's how you can go about it. Of course, viewer is better, but if we have no option, then we have no option but to look for the films. But always try to follow the structures. Like wherever you're seeing one structure, just follow around the same area in the next image immediately, so that you get a better idea of what's happening.
right. So I think with that, we can conclude today's webinar. And thank you so much for sparing your valuable time. And I must also apologize for having stolen your valuable family time on this weekend. So looking forward to have you on further webinars. And I think the viewers and our whosoever has witnessed and will be seeing the recorded versions also will be very much benefited. And we are very well hopeful of hosting you again very soon. So thank you so much. Thank you so much, Dr. Stanjin, for giving such a elaborate presentation.
Thank you for the opportunity.
So with that, I think we can call the day off and we can maybe stop the webinar now.
Okay, thank you so much.
Thank you. Thank you so much. It was a pleasure. It was real pleasure, and there's so much of learning there in your presentation. And definitely, I'm sure, like with further series to follow, we are going to be benefited a lot. So thank you again, Dr. Stanjin, and good night.
Good night.